Okay, great. Pleasure to be here. I was asked to say a little bit about modeling burdens. And what happened? Okay, so what I want to talk about is a little bit about really, I guess, how an economist would model these things. And we have the concept of individual utility functions, which represent individuals' preferences, which we often take to be roughly the same as their well-being. They prefer things that make them better off, and also are predictive of their choices. They choose things that make them better off. And I'll distinguish that from the problem of aggregating across people where we have a society. So for an individual utility function, this will characterize the individual's preferences and choices. That's useful to predict their behavior. If we introduce some ordeal or some other institution, we want to know how people will act, and also useful to evaluate their well-being. Typically, multiple attributes go into a utility function. We care about lots of things: income, free time, dignity, health, many other things. We can estimate people's preferences for one attribute relative to another. We think of marginal rates of substitution, the rate at which somebody will give up a little bit of one desired attribute for a little bit more of some other desired attribute. So there's a whole giant field devoted to estimating these things empirically, either through revealed preference methods, where we look at people's behavior in the real world, assume they prefer the things they choose over the things they could have had instead. And from that, we can infer something about the shape of the utility function, or stated preferences, which are essentially surveys where we present people with hypothetical choices and ask, if this was a choice you had to make, what would you do? It's important to say here we can estimate rates of substitution between attributes. We don't think we have any way to objectively estimate level of utility, how much utility is improved by changing from one circumstance to another, like avoiding an adverse health effect. And also, we don't have any objective way to compare who is better off, or if some good is given to one person or another, who gains a greater amount of well-being from that. So that's the problem of interpersonal comparability that, at least in conventional economics, we think cannot be solved objectively. One further point is the question whether people actually know their own preferences, whether they know which choice will make them best off. Clearly, we have imperfect information about most things over which we make choices, and we make a lot of choices without thinking very carefully. We're subject to a variety of behavioral biases and the like. So typically, for evaluating welfare at least, we're interested in what we would call normative preferences, which is some idea of people's reflective, informed preferences, the ones that they really believe they wish to follow, even if they don't always. So that's the individual side. Then we have the social evaluation side, where we have the problem of aggregating changes in well-being across people. One way you could do this formally would be with a social welfare function, which is a function to which the inputs are individual people's utility. And I've already said we don't know how to measure utility in an interpersonally comparable way. So we essentially have to make some choice about how we're going to standardize, how we're going to solve that problem. And then typically we would distinguish two attributes of an outcome: efficiency, where the key idea is a Pareto improvement. If we can make a change in society that helps some people and hurts nobody, that's a Pareto improvement. That's thought in general to be a good thing. If an efficient solution is one where you can no longer make Pareto improvements. And then there's the question of distribution, about which we've talked quite a lot the last couple of days, where here I'll just focus on the difference in well-being levels between people as one aspect of what we care about. So let me illustrate with a very simple example here. I have a society with two people, rich and poor. There are three attributes of concern: income, Y, time or free time, T, and health, H. Then I have here utility functions, UP for the poor person, UR for the rich person. So for the poor person, I write utility equals F of income plus time plus health. So the key point there is income plus time plus health tells me the rate of substitution between these three attributes, at least for small changes, is on a 1-for-1 ratio. So you just have to measure income, time, and health in appropriate units such that you have a 1-for-1 ratio. Then there's some function f applied to that. All we know is it's increasing. More y, t, or h is good, but I can't really say anything about how big f is, how steep it is, and the like, only that it's increasing. For the rich person R, I have a similar function G, which is monotone increasing just like F, but I don't know the shape or the level. And here I'm saying the rich person, who presumably has high income and less time, might value time relatively more in dollar terms than the poor person. So his rate of substitution between income and time is at the rate alpha. He'll give up alpha dollars for a unit of time, whereas the poor person would give up only $1 for the same unit of time. So alpha is bigger than 1. And then I assume they treat their rates of substitution between income and health are equal, but you could change that as well. Okay, and then I am going to assume that the rich person is better off than the poor person. Then I'm going to look at policies where we have 1 unit of health which is made available to each person, and it's up to them to accept it or not, depending on the terms. So here, the top row is the baseline. So the rich person starts off, here I've dropped the G and the F, I'm looking at the arguments of the utility function. So for the rich person, it's Y plus alpha T plus H. For the poor person, it's Y plus T plus H. I use big letters for the rich and small letters for the poor just to indicate that the levels might differ between these two people. So that's the baseline. Then we could make this health improvement available at a money price of P to each person. The P has to be smaller than 1 for each person to be willing to buy it. And if they do, the rich person will have income Y minus P, have health H plus 1. Similarly, for the poor person, the increase in total utility compared with the baseline is 2, because they each get 1 unit of health, minus 2p, because they each paid p to get this. And then, is there any change in inequality? No. Both people got a gain of 1 health unit, and they paid a cost of p dollars. So at least measuring in dollar terms, there's no change in inequality. Now so I'm assuming you have to pay the money price because there's some cost of producing this health increment. We could add to that a time price, Q. And if Q is small enough such that both people will buy it, we see the rich person now has utility Y minus P plus alpha times T minus Q, Q being the time price, plus H plus 1. For the poor person, it's the same, except alpha doesn't appear. Now the increase in total utility is the 2 minus 2p we had before, minus this time cost, which aggregated over the two people's Q times alpha for the rich person, Q times 1 for the poor person. So the increase in total utility is obviously less because we've imposed this time cost on society. Now there is a decrease in inequality because the time cost hurts the rich person more than it hurts the poor person. What if we make the time price large enough such that it's no longer worthwhile for the rich person to accept the health increment? So he will now have the same position as at the baseline. The poor person will still buy the health increment. So the increase in total utility now is 1 minus P minus Q, which is smaller than the increase we got with just the money price alone with no time cost. And there is a decrease in inequality because the poor person gains. He wouldn't buy this health increment if it wasn't worth more to him than the money price plus the time cost. The rich person has no change, so the difference between them is decreased. Then finally, one further policy you could think of is go back to just the money price, but assume we have a way to transfer money between people through taxes or differentiated prices to the two people or whatever. And at the extreme, that transfer could be equal to P. So now the rich person pays the price P and also pays P for the poor person to get the good. And the rich person gets 1 unit of health. The poor person pays the price P, but then is reimbursed through the transfer, so his net money cost is 0. He gets the good H. So now the increase in total utility is 2 minus 2P, just as in the case with the simple money price with no transfer, but inequality has been reduced by the amount 2P. So that's it. Thanks.
Hey, good morning. Thank you. So I have prepared a few slides for a brief overview of simulation modeling and their application in healthcare. And I'm hoping to introduce simulation modeling as an alternative approach to study ordeals in health. So I'd like to start with something that I believe we are all familiar with, statistical models. And statistical analysis. So in these types of analysis, we rely on statistical models to study if variable A is related to variable B. Okay, example would be, does smoking increase the risk of lung cancer? So in these type of studies, we usually have some hypothesis here. The hypothesis would be maybe smoking increases the risk of lung cancer, and then we design the study, we collect data, and then we run the analysis to test the hypothesis. Another example would be, does using mammography at certain age increases the life expectancy of women? So the main maybe characteristic of these studies is that we have some specific outcome of interest, this example, life expectancy or the risk of lung cancer, and there are some hypotheses to test with respect to that outcome of interest. And we need to collect data to run our analysis. So there are many scenarios where running experiments to collect data is unethical or infeasible or expensive. A typical example, imagine that we have an emergency department in a hospital, and currently we have 5 operating rooms available to this emergency department. A legitimate question would be, how much would we save if we decrease the number of available ORs from 5 to 3? Okay, so if I want to run these experiments just to answer how much money I would save, I need to kind of ignore 2 of the already available ORs. And if a patient comes and needs surgery, if 3 of the operating rooms are already occupied, it would be considered unethical to keep the other 2 operating rooms closed only because I'm interested to know how much money I would save. So this is, because of ethical issues, we would never be able to run these experiments. On the other side, if I'm interested to know how much waiting time I would reduce if I add 2 additional operating rooms, this is considered kind of expensive and infeasible. So we wouldn't build 2 new operating rooms and then staff them and equip them only because we are interested to know how much waiting time we would decrease. So in these examples that either, again, because of ethical issues, cost, or feasibility, we cannot run these experiments to collect data, we often rely on simulation modeling. So a brief kind of definition of simulation modeling to make sure that we are all on the same page. So these models are computer prototypes of a physical system, such as a hospital or a healthcare system, where the main goal is to generate evidence about how the system would behave under different specifications without implementing them in real life. So there are two characteristics of this model that I would like to emphasize. One is that these are prototypes of a physical system. So what matters in simulation modeling is essentially the physics, the mechanics, or the dynamic of the system that we are interested to study. So a lot of people compare these models to a video game, okay, except that we often don't have such visualizations in the models that we develop. So a simulation model of an emergency department would capture the arrival of patients over time, and depending and using some maybe historical data, we would determine the reason that they are visiting the emergency room. Is it because they were in an accident? Is it because they had heart attack, they had stroke? And depending on historical data, we would again decide what type of service they need. Do they need blood transfusion? If they need, what is their type? Do we have their blood available in our hospital? If not, we would need to send someone to get the blood, or we need to transfer the patient to another hospital. Or do they need surgery? Is there any operating room available to perform the surgery of the patient? If not, the patient has to wait or join the queue. Or if it is a life-threatening situation, we need to transfer the patient to another hospital. So all these interactions and the dynamics are being captured in these types of model. And the second important characteristics of this model is that we would like to study something without implementing it in the real life. Again, because of the ethical issues or cost issues, or it's just impossible. So the advantage is that when we create this virtual reality, now we can play with it and see what happens to many performance measures that we might be interested under different specifications. So in the context of ordeals, we learned that ordeals or rationing to inconvenience could lead to more efficient allocation. It could worsen disparity, would impact individual and population health. It could be wasteful because people have to fill out forms. It could increase administration costs. The maybe advantage of simulation model is that now we can assign numbers to these criteria. We talk about the impact of ordeals on these outcomes, but now we can measure them and we can assign numbers and to these criterions. And also it makes us think about what do we mean by efficiency, as pointed out in the panel. So a lot of people think about efficiency as sometimes a ratio of outputs to input, for example. So if we have two systems, A and B, if system A can produce more outputs for a given or the same inputs, then we would say system A is more efficient than system B, or we can think about it in the terms of Pareto efficiency that was mentioned by the previous speaker. And disparity, what do we mean by disparity? So when we create these models, the goal is to assign numbers to these disparities so that we can see if we change the ordeals, if we introduce a new ordeal, what is the percentage increase, or what is the amount of change in the disparity. And similarly, impact on individual and population health. There are different methods to actually quantify health. Many of you are familiar with disability-adjusted life year or quality-adjusted life year. And there are different ways to measure time and assign some monetary value to time. So the goal is to capture these in a unifying framework so that we can have numbers when we compare these. And so this all sounds good, but the main kind of difficulties in using and developing this simulation model is that we need to know enough about the physics and the mechanics of the system that we are going to simulate. James talked about the utility theorem. That's essentially what a lot of people are using to capture the way that people are making decisions. So in in the context of ordeals to decide about whether to use a service or not. That decision depends on maybe the service price, the distance to the service location, the waiting time in line, time to fill out the forms, and the health benefits. So we have some attributes that each patient or each individual would evaluate, and then they decide to use the service if their gain in their utility by using the service would be a function of, again, price, distance, waiting time, and many other attributes is greater than 0. So in a lot of practical examples, we may not have a good estimate for U, but as also mentioned, there are different methods to characterize this function. And so that was essentially my brief overview of simulation modeling and how we can use it in testing different specifications or different ways to design an ordeals without actually implementing them in real life.
So thanks. I'm going to take my prerogative as moderator to start us out with a question. So, these are sort of really interesting models. One question that comes to my mind, I think about the places that I work, where resources are really scarce, and I wonder, do we have enough data to do modeling exercises around ordeals? Do we know enough about the inputs to the models? I'm thinking about waiting time. Most low resource health systems don't have any measures of waiting time. I was sort of interested in waiting time and had to collect my own data. I actually sat a receptionist in health facilities and recorded, when people came in, when they got services, and how long they waited. That data, isn't sort of readily available. So, where do you think we are in terms of, how much data we know, we have, what do we know, and what would we need to know to sort of do some serious modeling of ordeals?
So I think that is definitely one of the main concerns in developing simulation models, and they are data intensive in terms of knowing what is happening in the system. However, in theory, you can create a model without having any data. You can make some assumptions, and over time, as you learn more about the system, you can improve the estimates of your parameters in the model. So, for example, if I want to create a simulation model to test an ordeal, again, I would just make some assumptions about this utility function. I would start with there, and then when you run your simulation model, you see some outcome, and if the behavior of the model is not consistent with what you expect, or it's not consistent with what you have observed in real life, then you think, okay, there's something wrong, so I need to revise it, I need to improve it. And but definitely lack of data to inform parts of the model is a main kind of challenge. At the same time, because running this simulation model is cheap, you can do your analysis with different assumptions, potentially as many assumptions as you like. And if it turns out that your conclusions remain insensitive to certain parameters or certain inputs, then say we acknowledge that we didn't have data to inform this parameter, but our conclusions remains the same. So that's a good thing. And also sometimes you can use this simulation model. Now a lot of people are using it to inform clinical trials to understand and inform areas where we need more data in order to make decisions more confidently. So I think, and the other thing I'd like to point out is sometimes, example is the utility function. We might not have good estimate in the context of ordeal, but there are many other areas that people have studied same questions, and they have good estimates about, for example, how people evaluate different attributes. So we might start from there, bring it in the context of ordeals, and if what we get is consistent with what we expect or what data, then it's good. If not, that means that we need to collect more data in those pieces to have more confidence in these models.
Excellent. Yeah, so just quickly, I think you can always have enough data for a model because you always have to, you never have all the data. So you always have some assumptions, and it's a framework for integrating what we know, how well we know it, and exploring whether we know enough to decide what to do, and if not, which pieces we need to understand better.
Mm-hmm. So we'll open it up to speakers, or Nir, did you look like you wanted
So,
to?
one thing that I would love for us to also think about in the modeling of this is pertains to something that came up a couple times in the conference. Many of the micro deals that we're talking about probably involve a discrepancy between how much they dissuade people from overconsumption and how much they actually damage them, actually harm them. They don't harm them much. In fact, walking to the other side of the village to cash out the coupon is good for your health and might actually be good for you overall. But because of the way we are constructed, behavioral psychology, we really don't want to do that. And so they have this nice motivating effect. That, to me, suggests that we need modeling for two different things. One is how much people are averse to the time loss, Another one is how much the time loss is, is bad for them. These are very different things. A normative premise that I would throw in is that egalitarianism, prioritarianism, etc., pertain primarily to the allocation of the really bad things in life, not so much from the point of view of justice to motivating factors. It's about, so the simulation should be done in quite different ways for these two categories of things that are actually demotivating and things that are actually bad for people.
Yes. No, I agree, and so one of the maybe one good thing about developing this simulation model is that then we realize how much we don't know about what we are actually trying to model, and in the process of developing, you will see that sometimes we have a very different perspective about a common thing and sometimes conflicting. But you can, create a model for each of these perspectives or each of these, scenarios, and then compare what happens if you're right. If for example, the ordeals require people to walk, you can run your analysis assuming that that's actually a good thing, or you can run your analysis assuming that that's a bad thing. And now where we are standing, you can compare the numbers in theory, at least, to see if the overall benefit of the society, does the ordeal changes the overall health of this population, or is it hurting the population?
And part of what you were saying, in my view, relates to the difference between positive and normative preferences. Positive preferences are the description of the preferences people must be maximizing given their behavior, and normative preferences are the preferences arguably they would like to satisfy, or we as impartial observers think they should be satisfying. And so if people think it's not worth walking that far for the health benefit, is a deep question: who gets to decide? Why is your view that this health benefit exceeds the displeasure from walking get priority over their perspective that the situation's reversed?
I was actually going to make a comment, something like James's, but it seems to me that we actually need both kinds of models, because we're interested in predicting what people will do. We're also interested in making some judgments about what kinds of harm or benefit. And so we have some difficulties in just using sort of off-the-shelf standard economic modeling. I mean, these are probably difficulties in general in welfare economics, but I think there's a lot to be worked out.
So I have another question. Is there one thing that wasn't in the models is sort of some kind of thinking about externalities? I mean, is there sort of an asymmetry where there's potentially more negative externalities from taking up people's time? You know, what I think of when Nir says it's more of a hassle than an actual cost, I think of, a woman who comes to antenatal care, waits 7 hours and leaves her 2-year-old at home by themselves. So, if you think about, is there an asymmetry in terms of negative externalities being much more likely to be present in time than money? And, I don't know, maybe they're completely the same, but.
I think it's context dependent.
Yeah.
And as was discussed on the previous panel, there's a lot of fungibility between time and money.
Sometimes. Yeah.
Yeah, I think externality is something that a lot of people can easily capture in these models because just for the chlorine example, if you are also interested in looking, what is the expected number of death in each arm, that's something that you can also add as to kind of extend your model, something to make it more realistic and to more comprehensive, above or beyond the trial that you were running.
I wonder if you could say a bit more about the issue that Jim has flagged about the positive and normative preferences. Maggie, your work is in behavioral economics, so we know that there are certain ordeals or other considerations will lead people to give up seeking care or otherwise steer them in a direction away from care for reasons that seem very clearly not to be in their interest, just because we're not very good at being completely rational. So, for example, with smokers, something I'm obsessing about right now, you can offer them an e-cig, let's say, and say, look, this will gives a 50% chance this will save your life. That's not going to do it if it requires anything of them. You have to make it so easy for them to do it that it's like falling off a log. If it requires anything, God knows if there's any increase in price or any decrease in pleasure, they just... Now, from the external observer's point of view, this is insane. Don't they realize their life is on the line? But that's what they do. Okay, so in terms of predicting, it's not so uncommon that in the health field, we know things that they're not using. It's information either they don't have or that they're ignoring or misusing. So it's fairly common. Using the models to predict what they're going to do is extremely important. But that's, in no way is that going to be a representation of what we think would be something that would increase either individual or social collective welfare. So keeping them separate is really important. And then when we mix in the externalities, I'm thinking, for example, that there may be times when you really want to inoculate everybody against some horrible disease if we had a good Ebola vaccine, for example. But, people will stand in line only for so long, or they'll walk only so far. And if it's too much of a bother, they'll turn away, But it really matters. We have to get every damn person, just like with eradicating polio, we have to get every last damn person. But to the individual, what's the big deal? I'm probably not going to get polio anyway. And so combining the personal utility functions is not going to do anything for us that because we have this extreme premium that we place on everyone doing it. Well, that's about it.
Just quickly on that point, as Richard Zeckhauser said yesterday, there could be situations where we want essentially a negative ordeal associated with vaccination. We pay people to get vaccinated and do things of that sort. But yeah, I agree completely with your main point that for predicting how people will behave, we need study of positive utility functions and learning all we can in detail about how people perceive things, systematic features of their behavior. But that is not necessarily at all the same as the function you want to use to evaluate their welfare. But there's a deep question, I think, in terms of whose judgments about welfare get priority. So clearly, lack of information. Nobody. I like this idea of what's it called? Rational ignorance, I think, is the term. The world is incredibly complex. None of us can learn enough about most choices we have to make them in an informed way. So it makes a lot of sense to delegate a lot of decision-making authority to government and to others, FDA and lots of other things, doctors.
Thanks again for the presentation. I had a question on whether you think it's possible to incorporate intersectionality into either of the two models. I'm thinking about a model that will take into account social determinants. I know here one example that has been brought more than once of an ordeal is making, I believe the example was, if you make doctors have to go through a laundry list of choices and then you put the expensive medicines at the bottom of the list, then they are more likely to prescribe the ones that are at the top. But then taking that into consideration, as well as the fact that there is, for example, some literature that exists that shows that both medical students as well as physicians, their perception of pain tolerance from the patient is different, whether they deal with a white patient or a black patient. And so when that example was brought yesterday, the first thing I thought about was, if the patient is a black person and now you're saying the doctor is supposed to go through an extra hassle to prescribe pain medication, you are basically putting them at an even higher risk than they faced before. And so I wonder if there is a way to incorporate that into any of the models, or it's just out of the blue.
I'd say if that's a systematic feature of physician behavior, it could well be incorporated in the model in terms of describing what people will do. And it seems to me the kind of this physician bias you're suggesting seems pretty separable from the choice of policy instrument like ordeal or other. We could subsidize, we could have subsidize the generic drugs, have restrictions on how many of the more expensive drugs can be used in a practice. They're
It's interesting because it could actually be, it would be an interesting study. It could be that you start out with very unfair prescribing patterns, where white patients get expensive, get sort of top of the line medication and black patients don't, and that actually adding an ordeal would make it more fair empirically by, giving, because you sort of so it's empirically it could go either way, but it does seem like it would be interesting to study the two at the same time. It could make things more fair if the ordeal defaults the doctor to always doing the same thing for every patient, for example. That may not happen, but it seems like a sort of something you could study the two together and actually measure the impacts.
Yes.
I'm a practicing physician, which I said yesterday, and one of my other interests is infant mortality. Boston has 3 medical schools, numerous teaching hospitals, but sections of Boston have very high infant mortality. And I'm wondering if you have any thoughts about how one would model why that continues to be the case. The public health services in Boston are well aware of this. They publish a lot of statistics about it. They try to intervene. But what could economic modeling do to explain why infant mortality continues to be such a problem? And in the United States in general, I mean, we're awful in the World Health Organization statistics.
I'm not sure if modeling would provide an answer, but I think when you try to model the situations, you may start looking at different factors. For example, is it because a lot of people live far away from hospital? Is it, when you want to capture the dynamics and the mechanics of your system, then you start thinking about the factors and the players. Is it because they don't visit doctors often? Is it, I don't know if developing a model would answer the question, but I think while you're developing the model, you might start looking at different factors because that's something you need to capture in the model, and maybe that way you get an answer.
Well, I think people speculate about lots of factors. Transportation is one. Living in a neighborhood where there are a lot of guns and violence is another. You don't like to go out. Mm-hmm. Poverty. Mm-hmm. It's a natural ordeal, or maybe a stressor would be a better way to put it. But I was just wondering if there was something that you thought economics could tell us. So.
Other questions? Hi.
Hi again. I was just curious. You said that simulation modeling, and I know your work is very mechanistic and really focusing on the model itself. You said that in the absence of data, you can in fact derive a model, develop a model using a number of assumptions and so on. And I was wondering, just out of curiosity, have there been any instance where public policy have been successfully developed with such types of models?
Yeah. So there was actually a study showing that a lot of the public policies, only a very small percentage of modeling studies will actually go into to inform public policies, because it's still something new, and maybe 1% or 2% of some of the, for example, the task force would look at the modeling study. So I don't have any.
I would say, so policy has, 1,000 mothers and fathers, and so it's very hard to know what factors led to development and adoption of a policy. For many, many policies in various domains, a lot of modeling goes on, which provides information which helps people, we hope, think about the trade-offs and what's likely to happen more clearly. In So cost effectiveness analyses of various medical interventions are widely used, and in the United Kingdom National Health Service have, as I understand it, quite a large effect on which things are paid for through the National Health Service and which are not. And I guess similar in Australia. In a field I work in a lot is environmental regulation, and for most kinds of regulation of that sort in the United States and to an increasing extent in other countries of the world, there is formal analysis of policies, the benefits and costs of them. And while that's not determinative of whether regulation goes forward or not, it's influential.
Yeah, I do like the idea, because when I'm seeing it now, I'm looking at normally public policy, certainly where I come from, is normally highly influenced by political ideology rather than objective criteria for decision making. So this was a nice little refreshing exposure that what if, you know? So thanks so much.
Yeah.
I think also that, you know, if you think about funders, large funders like the Gates Foundation, for example,
Yes.
a huge percentage of the decisions about how they decide where the money should go and how to prioritize is based on models with varying levels of data inputs.
Yeah.
So a follow-up question for me as somebody who collects data, you know, as you thought about modeling Ordeals, you know, what's the one or two pieces of data that you think that are most glaringly missing, or that would make the biggest contribution to sort of improving the model's ability to be useful?
I would say any data that allows you to better estimate these utility functions to better capture the way that people make decisions
Trade-offs.
and trade-off between, you know, time, money, distance, waiting. I think that would be maybe very useful.
Yeah, I think it depends a lot on what the ordeal is, what the population is, what is relevant.
Yeah. A lot of time you don't know exactly what data you need until you start
it.
building the model, and then you see that, well, there are so many pieces that I do not have enough knowledge or information how to represent, and that informs sometimes the data collection activities.
Now, there are no more immediate questions. We could take a 15-minute break now and reconvene for the final session, where we'll try to bring everything together to bear on some, you know, what could be done in practice following all of these many preliminary and theoretical discussions that we've had. And thank you very much. The three of you.